Good morning, everyone. Thank you, Dr. Bharti, for giving me this opportunity. I'll be talking about the use of toric ICLs and toric IOLs in patients of keratoconus. I have no financial interest. Toric ICLs in keratoconus. Now, once you've diagnosed and you've treated, it's not coming. So once you've diagnosed and you've treated, now the patient has a question, what do you do about my vision? Visual rehabilitation is an important part of keratoconus management, especially post C3R. So traditionally what we've seen is that spectacles work very well for early keratoconus, although the quality of vision may not be very good. And the mainstay of treatment has been contact lenses, especially RGP lenses. However, the quest for everyone wants spectacle independence, and nowadays very early keratoconus often gets detected when they come for a LASIK treatment. And therefore these modalities for such patients have come up, like to enhance the quality of vision and to enhance the quality of life. Phakic IOLs are a relatively newer but exciting modality for keratoconus patients. They are recommended when the cornea is stabilized, either due to the natural stoppage of progression after a certain age or post C3R. Patients usually have myopic astigmatism and they often require a toric phakic IOL. The one I'll be talking about is toric ICL. It's implantable columnar lens. It's a posterior chamber phakic IOL by the Star Surgical company. So as you must have all seen this, it's a 50 micron optic that they say. It's a very thin, it has to be handled very delicately. So let's see why toric ICL and what is the difference with RGP, because RGP lenses we know work very well. So one thing you have to see that visual acuity post toric ICL implantation may not be as good as with a well-fitted RGP contact lens in keratoconus patients. Now this may not invariably be so, but this is usually so. And it is important to highlight this fact to the prospective toric ICL patient, and because there is irregular astigmatism in keratoconus, and RGP lenses, as you all know, forms a tear lens which is actually responsible for the good visual acuity that such patients have. And this tear lens factor is absent in toric ICLs. Toric ICLs effectively function like a spectacle. So our RGP lens creates a smooth, even-shaped surface to see through. A lens system, an optical system is formed with the RGP lens anteriorly, the patient's cornea posteriorly, and the tear film getting filled in, forming the tear lens. And by modulating the curvature and the power of the RGP lens, we can correct the refractive error. So this important factor is going to be missing in toric ICLs. And we can see that the patient correction with toric ICLs is up to myopia of 0.5. Now they've enhanced the range to -18 and cylinder up to 5 diopters. This cornea should be stable, the refraction should be stable, and the anterior chamber depth should be more than 2.8 counted from the endothelium. This is the new one, the one with the hole that's come in. It's called Visian ICL with central flow technology and the KS Aquaport. It has a central optic port of 360 micron, thereby eliminating the need for PIs, and offers increased comfort and efficiency for the patient and surgeon. This is essentially the design. You see this 360 micron hole here, and the perioptic holes also which are present. And basically, toric ones would have this extended alignment marking in the center here, which will help you align. So preoperative planning. Basically, there should be accurate and stable refraction should be there. This is very critical. The anterior chamber depth from the endothelium should be checked. It is again critical, and wide to wide diameter is very, very critical. In addition, we see pachymetry, keratometry, specular microscopy, although not used in the toric IOL calculation. The back vertex distance is assumed to be 12. And then we select the ICL by logging on to the website provided by the company. And as I said, horizontal white to white measurement is very, very critical here, and best measured with a digital caliper, and patient is lying supine under a microscope. Although people do it on a slit lamp also, but I personally feel this is better. It can be validated by an OB scan with the iMetrix tool or the newer Pentacam software. So anterior chamber should be 2.8 millimeters minimum. And please remember that in a phakic IOL, you're working in a cataract. When you're doing a cataract surgery, there's almost 7 to 8 millimeters of space that you eventually end up with. But here the working space is about 3 millimeters at the most, which is quite less compared to the cataract surgery. So you have to be very careful. This is the calculation software page. And preoperative preparation, you have to do, now with the newer version, you don't need peripheral iridotomies, but the older version is still available. So 1 to 2 weeks prior, you can do a YAG PI. There are 2 PIs performed, and you can do it operatively with a retractor also. And the PIs, if you're doing it, they must be large and patent, kept mid-peripheral, and inadequate PIs can cause post-op complications like an iris Bombay formation or shallow AC and increased intraocular pressure. We have to, before the surgery in a toric IOL, you need reference points because we know that the eyes can undergo torsion movements. So there are various ways of marking the reference points. 180 degrees is what we try to mark. Sometimes you can have a one at 270 also. And there are various devices available, various ways of doing it. But what I finally boiled down to is that you make a horizontal slit and bisect it on a slit lamp and then mark the 2 points here. But you can use any technique which works well. Then on the table, you would need to mark the relevant axis at which the toric ICL has to be placed. So here we use an axis marker, and then there are instruments available which will mark the axis. So this is where you align. And these are the positioning marks that are present in toric ICL. This would not be present in the regular spherical ICL. Surgical technique overview, the ICL is oriented, marked on the cornea, 1 or 2 paracenteses, ICL orientation is marked on the cornea, 1 or 2 paracenteses are made, viscoelastic is injected, a temporal clear corneal incision is made, the ICL is injected in very carefully, and then once you've placed it in, the foot plates are lying in front of the iris, you place some viscoelastic on top of the ICL, and then position the ICL behind the iris, and then an irrigation and aspiration of viscoelastic is done, and pupil can be constricted, or that's a personal choice too. So the central part, the optic part, is very thin and delicate. It should be a no-touch zone. I'll show you a video. So loading is very critical. It has a specific cartridge which is provided by the company. You fill it, load it, first charge it with saline, and then put some viscoelastic. Then the lens is taken out from the bottle. It comes packed in a, there are 2 types. The latest one is coming in BSS, with the one with the hole. The earlier one was saline. Then you position the lens. And there are special forceps with which you would pull it. You would pull the lens in the cartridge. So here you go, these are special forceps, ICL holding forceps. You gradually pull it very carefully. This should be a very careful procedure because the lens can get damaged. Then it's fitted, the cartridge is fitted in the injector. The axis is marked. This is how you mark the axis at which you want to leave the lens. Then keratomy is used to make an incision. It's filled with viscoelastic. It's filled through the side port. And you can see those strands. That's how you need it. You don't want an overfill. And then the ICL is injected very gradually with soft tapping movements. You'll see it unfurl. Leave the 4 foot plates. Leave them in front of the iris. Don't try to tuck it in while injecting. Once it goes in, then with the special manipulator, you can tuck the foot plates behind the iris. You see that? Do an irrigation aspiration, and that's the end of the surgery. So post-op medication is pretty much routine, like a cataract surgery, antibiotics and steroids topical 4 to 6 times per day, and then the steroids being tapered. You can see the volt here. This is the crystalline lens. This is the ICL. There is a volt here. Less than 0.5 times the corneal thickness is a low volt with a risk of cataract formation. 0.5, that means 250 microns, half the corneal thickness, to 1.5 is the ideal volt, and more than that is a high volt with a risk of glaucoma coming in. So I've done about 25 eyes, although the analysis of about 7 eyes of 5 patients, all underwent C3R followed by toric ICL, and the 2 procedures were separated by 26 months. And all patients had an improvement in the UCV and BSC, best spectacle corrected visual acuity. There was mean improvement of 5 lines of UCV and 2+ lines of spectacle corrected visual acuity. None of the patients lost any line of BSCVA. Studies, there's not much reported literature. There's just 13 studies in Medline Search, 9 of which were series and 4 case reports. The results are quite similar to ours. Some practical tips: ensure stability of refraction. It should be done only in mild to moderate keratoconus. Bow tie pattern with minimal skewing is the ideal. Avoid significantly shifted cones. Personally, I proceed only if the autorefractometer is able to pick up the refraction, because with a retinoscope you can do a lot more. And subjective refraction takes precedence over objective refraction. So if your axis is coming on keratometry, let's say 20, but we've seen in keratoconus patients, it's because it can be shifted. Your actual acceptance axis would be 60. Go with the actual refraction. Be realistic and inform the patient. And basically, it's a promising modality, but we need to learn more about it. And there's still early days for toric ICLs. I'll quickly cover toric IOL in keratoconus. So basically, patients with keratoconus and cataract present some unique challenges to the surgeon. The use of toric IOLs in keratoconus is a more complex affair compared to toric ICLs. The reason being, with the toric ICL, you are actually doing a refraction. You just place the axis, whatever you get, you align the axis on that. However, in toric IOLs in a patient of cataract with keratoconus, the issue involved is first to do or not to do, then the alignment, keratometry, and biometry. This is to do or not to do is the big question, because will the patient benefit from toric IOL at all? Or would he be better off with the regular spherical IOL followed by RGP contact lens after surgery? Because many of these patients of moderate to advanced keratoconus would already be using RGP, and the reason we had to give them RGP was because spectacles were not working for them. And the toric ICL would effectively work like a spectacle. So this issue may persist after cataract surgery, because toric IOLs would function like spectacles only. Then once we decide, okay, we want to go ahead with this patient, so the IOL alignment issue would come in, as I mentioned earlier, that the axis sometimes is very different, and if you're not able to refract, you would go with the keratometry axis, which may not be the right axis for the patient, and you may end up with resultant unpredictable astigmatism. So keratometry, of course, is very difficult in advanced to, in mild to moderate, it's not difficult at all. You can go ahead with the decision, yes, I'll do toric IOL. Question is in moderate to advanced keratoconus, because keratometry may not be accurate, and however, we should rely on topography more than keratometry. Biometry, again, the axial length may be inaccurate. More importantly, what formula to use, we are still not sure. And because they make an assumption, all formula make an assumption about the effective lens position based on K values and axial length. And K values are really going haywire over here. So SRK-T, as of now, may be the most accurate. However, we need to look at Holiday 2 and Barrett Universal 2, although the second one functions primarily like SRK-T. Surgery is essentially the same as that for any toric IOL implantation. Do not attempt limbal relaxing incisions or astigmatic keratotomy in a patient of keratoconus having cataract. This is definitely not to be done. I think I'll skip the video in the interest of time. And in terms of studies, not much reported literature. 10 studies in Medline Search, 6 series, 4 case reports. Literature suggests careful case selection with good results in mild to moderate keratoconus, poorer results, and need for RGP in moderate, post-surgery in moderate to advanced keratoconus. In conclusion, mild to moderate keratoconus patients will have better and more predictable result. As the corneal irregularity increases, results get progressively unpredictable. We need to seriously consider whether toric IOL would be the best choice for that specific patient or not. And careful case selection can give gratifying results. And surgical technique is essentially the same. And as I said, do not attempt limbal relaxing incisions. And this is possibly one situation where an early cataract surgery, while the patient is still refractable, may be gratifying. Thank you for a patient hearing.